Good morning, I'm Antonio Facciorusso from the Endoscopy Unit of the University of Foggia, Italy. On behalf of my colleagues and co-authors, I will describe the results of a recent article published in Gastrointestinal Endoscopy entitled Comparison between Fine Needle Biopsy and Fine Needle Aspiration for Endoscopic Ultrasound-Guided Sampling of Subepithelial Lesions and Meta-analysis. Subepithelial lesions are detected incidentally in 0.8% to 2% of patients undergoing routine upper gastrointestinal endoscopy. Since a definitive diagnosis can rarely be established only on imaging morphology, tissue acquisition plays a pivotal role in the management of these lesions. Bite-on-bite forced biopsy, in particular JAM1 roofing technique, represents often the first-line approach able to determine variable results in terms of diagnostic yield, ranging from 17% to 94%, so a very wide range. Endoscopic ultrasound fine needle aspiration did not prove to outperform bite-on-bite biopsy, and the recent meta-analysis found that pooled diagnostic yield of endoscopic ultrasound-guided sampling in patients with subepithelial lesion as high as 60%. There is currently limited evidence on the diagnostic performance of newer biopsy needles in patients with subepithelial lesions. Aim of this meta-analysis was to compare endoscopic ultrasound-guided fine needle biopsy performance to fine needle aspiration in patients with gastrointestinal subepithelial lesions. Primary endpoint was sample adequacy. Secondary outcomes were diagnostic accuracy, optimal histological core procurement rate, and mean number of needle passes through the lesion. Safety data were also analyzed. We included 10 studies, 6 randomized trials and 4 retrospective studies enrolling 669 patients. The most frequently used fine needle biopsy device was 22 gauge Pro-Core needle, while newer biopsy needles, Sharp Core or Acquire, were tested in only 4 studies. This is our primary outcome. Sample adequacy. Pooled rates of adequate samples were 94.9% with fine needle biopsy and 80.6% with fine needle aspiration respectively. Fine needle biopsy clearly outperformed aspiration in terms of sample adequacy, odds ratio 2.54. Of note, when rapid on-site evaluation was available, no significant difference between biopsy and aspiration was observed, although a positive trend in favor of biopsy was registered, odds ratio 1.60. Optimal histological core procurement rate was 89.7% with fine needle biopsy and only 65% with fine needle aspiration. Again, fine needle biopsy resulted significantly superior to fine needle aspiration, odds ratio 3.27. Diagnostic accuracy resulted as high as 87.9% with biopsy and only 64% with fine needle aspiration. So the odds ratio was 4.10. Analysis of the number of needle passes needed to obtain adequate samples showed a significantly positive trend in favor of fine needle biopsy, mean difference minus 0.75. No significant adverse events were observed. Therefore, there are some limitations to our study. First of all, the low number of included studies and enrolled patients require particular attention in interpreting our results. Second, subgroup analysis based on the location of the sample lesion was unfeasible due to the lack of individual patient data. Therefore, our findings should be considered to be applicable only to upper gastrointestinal subepithelial lesions, in particular gastric lesions. Third, the impact of certain technical aspects, such as use of stylet, fanning, or slow pool technique, could not be explored due to the low number of available studies. In conclusion, our results speak clearly in favor of fine needle biopsy, which was found to outperform fine needle aspiration in all of the diagnostic outcomes reported and evaluated. New generation devices, Franzen and fork tip biopsy needles, seem very promising but need to be explored in further studies.